Welcome to the Endo Kids podcast, the podcast where we help families navigate the ups and downs and in-betweens of growing up healthy. I'm Dr. Rinku Mehra, the founder of Endo Kids Concierge and a pediatric endocrinologist, and my co-host is Dr. Lindsay Waldman, who is also a board-certified pediatric endocrinologist. We are here to break down the science of hormones, share real stories, and answer the questions parents wonder about the most. So whether you're worried about growth, puberty, thyroid, or just want to understand your child's development a little bit better, you're in the right place. We believe every family deserves answers, support, and a caring partner in their health journey. So grab a cup of coffee, get comfortable, and let's tackle this topic together today. This podcast is for educational purposes only and is not a substitute for medical advice. Please consult your child's healthcare provider for individualized care. Hi, everyone, and welcome back to the Endo Kids podcast. I'm Dr. Rinku Mehra, pediatric endocrinologist and founder of Endo Kids Concierge. Today's episode is a very important one because we are discussing a major shift happening in endocrinology and women's health. As many of you may have seen in the news recently, the condition historically known as PCOS, polycystic ovary syndrome, has officially been renamed PMOS, which stands for polyendocrine metabolic ovarian syndrome. This change was recently highlighted in national media coverage, including the Associated Press, and it reflects years of discussion among endocrinologists, gynecologists, adolescent medicine specialists, researchers, and patient advocacy groups. And honestly, this is much bigger than just changing a name. This reflects a major shift in how the medical community understands this condition, because for decades, the name polycystic ovary syndrome unintentionally gave patients and even physicians the wrong impression about what this disease actually is. The old name heavily focused on ovaries, cysts, fertility, but the reality is that this condition is endocrine, metabolic, hormonal, reproductive, and systemic. And many experts now believe the old name failed to capture that complexity. So today, we're going to go deep into what PMOS actually is, why the name changed, why this matters for teens and women, and the metabolic side that often gets ignored. We're also going to talk about the emotional burden patients experience and insulin resistance, some misconceptions about obesity, fertility myths, treatment approaches, and what parents should understand. I also wanted this episode to serve as a deeper educational discussion beyond the short television interviews and media clips that are circulating right now. So let's start at the beginning. For years, most people thought PCOS meant that you have cysts on your ovaries. And honestly, that misconception makes sense because the name itself reinforced it. But here's the reality. Many patients diagnosed with PCOS never actually had ovarian cysts, and the structures seen on the ultrasound are usually not dangerous cysts. They're immature follicles, tiny egg sacs that did not complete normal ovulation. That distinction matters medically, but it also matters emotionally because patients hear the word cyst and immediately think tumors, surgery, cancer, infertility, something dangerous. And for many patients, that creates unnecessary fear. The old terminology also narrowed the focus too heavily toward the ovaries, but the condition affects the entire body. And honestly, one of the biggest problems with the old terminology is that it minimized the metabolic side of the disease. So let me be clear, PMOS is not just a gynecologic condition. It is deeply connected to insulin resistance, metabolism, inflammation, cardiovascular risk, diabetes risk, liver health, skin, mood, sleep, and weight regulation.
This is why many endocrinologists feel the terminology needed modernization. So let's talk a little bit about why the name was changed. This name change did not happen overnight. According to reports discussing the international consensus process, this was years in the making. Experts from around the world participated in discussions about whether the old terminology was still medically appropriate, and patients themselves were part of the conversation. That matters because many patients with PCOS have long expressed frustration that the name did not reflect their experience. It caused confusion, it minimized their symptoms, and it overly focused on fertility and the ovaries. The new term is polyendocrine metabolic ovarian syndrome. So let's say that again, polyendocrine metabolic ovarian syndrome. And let's break it down. Polyendocrine means multiple hormone systems are involved. It's not simply an ovarian condition. The brain, the insulin system, the adrenal system, the ovaries, metabolism, and inflammatory pathways are all interconnected. Metabolic. This is probably the most important addition because insulin resistance and metabolic dysfunction are central components of the disease for many patients. Now, ovarian. The ovaries still matter. Ovulation and androgen production remain important parts of the condition. And the word syndrome, meaning a constellation of symptoms that can vary dramatically between patients. So some patients have irregular periods, they have acne, hair growth, increased weight gain, insulin resistance, but others may primarily struggle with infertility or thinning hair on their scalp or metabolic disease. No two patients look exactly the same. Now, let's talk a little bit about why pediatric endocrinologists care so much about this. One thing many people do not realize is that symptoms often begin during adolescence. This is not simply an adult fertility disorder. As a pediatric endocrinologist, we often see rapid weight gain, irregular periods, acne, insulin resistance, elevated testosterone, excess hair growth, scalp hair thinning, and metabolic abnormalities. Starting in middle school or high school, and honestly, adolescence is one of the most difficult times to diagnose this condition properly because puberty itself can mimic PMOS. For example, irregular periods can be normal in early puberty. Acne is common in puberty. Hormones fluctuate naturally in puberty, and ovarian follicles can appear normal on ultrasound. That is why organizations like the Pediatric Endocrine Society, American College of Obstetrics and Gynecology, and the North American Society for Pediatric and Adolescent Gynecology have emphasized caution when diagnosing adolescents. Ultrasound alone should generally not be used to diagnose PMOS in teenagers, and that's very important. Instead, we look at persistent menstrual irregularity, evidence of androgen excess, like hair on the face or hair on places that women don't want to have hair typically. So, upper lip, chin, chest, those areas, elevated testosterone, severe acne, insulin resistance, and metabolic dysfunction. And honestly, balancing overdiagnosis versus underdiagnosis can sometimes be difficult. But some girls struggle silently for years without answers, and others may be labeled too early. Both situations can cause harm. So let's talk now about insulin resistance, the piece that many people miss. This is truly central to understanding PMOS. Many patients with PMOS have elevated insulin levels, and insulin is not just a blood sugar hormone. Insulin also affects the ovaries. High insulin levels stimulate ovarian androgen production. That means elevated insulin can drive increased testosterone, acne, facial hair growth, scalp hair thinning, and irregular ovulation. This creates a vicious cycle, and for many patients, insulin resistance begins years before diabetes developed. That is why PMOS is associated with prediabetes, type 2 diabetes, fatty liver disease, elevated triglycerides, high blood pressure, and risk of heart disease. And honestly, the old terminology did not adequately highlight those risks. Many patients thought this is only about fertility, but it's not. It's the whole body endocrinology. And this is one reason the word metabolic was intentionally added to the updated terminology, because experts wanted patients and physicians to understand that this condition affects long term health far beyond reproduction. Now, we need to talk honestly about weight because this is often one of the emotionally painful parts of PMOS. Many patients with PMOS struggle with weight gain, intense hunger, difficulty losing weight, abdominal fat accumulation, and metabolic slowing. And unfortunately, many patients feel blamed. They are told, you just need more willpower. You're lazy. You're not trying hard enough. But biology matters. Hormones matter. Insulin resistance matters. Inflammation matters. This does not mean lifestyle is irrelevant. Lifestyle absolutely matters. Nutrition matters. Exercise matters. Sleep matters. Stress management matters. But it's inaccurate and unfair to pretend that this is simply a motivation issue. And importantly, not all patients with PMOS have obesity. Lean PMOS absolutely exists. Some patients are thin, athletic, highly active, and still have significant hormonal abnormalities. So that's another misconception. Let's talk a little bit about the mental health impact because this part deserves much more attention. Patients with PMOS experience higher rates of anxiety, depression, body image distress, social withdrawal, eating disorders, low self esteem. And honestly, this is understandable. Think about what many patients are dealing with simultaneously: acne, hair loss, unwanted facial hair, weight struggles, irregular periods, fertility fears, chronic frustration, dismissal from physicians. Many patients feel deeply misunderstood. And one thing I repeatedly tell families is this: PMOS is not a moral issue. It is not laziness. It is not simply lack of discipline. There are real physiologic and hormonal drivers involved. Compassionate care matters enormously. I want to talk a little bit about fertility fears and misconceptions because one of the biggest fears patients have is, will I be able to have children? And honestly, the old terminology contributed to that fear because once patients heard ovarian syndrome, many immediately assumed infertility. But here's the reality: many women with PMOS conceive naturally. I'm going to say that again. Many women with PMOS conceive naturally, but others may require medical support. But PMOS does not automatically mean infertility. Now, ovulation can absolutely be disrupted. Some patients ovulate regularly or not at all, but treatment exists, and outcomes are often very good. This is another reason the terminology update matters. The old name unintentionally narrowed the public conversation almost entirely towards fertility and ovaries. Meanwhile, patients were struggling with metabolism, mental health, insulin resistance, inflammation, sleep, cardiovascular risk, and those pieces deserve equal attention. Let's talk about how we treat PMOS. This treatment should be individualized. There is no single PMOS medication. Management depends on age, symptoms, metabolic profile, fertility goals, mental health, and patient priorities. Treatment approaches may include lifestyle interventions, resistance training, cardiovascular exercise, protein optimization, and reducing ultra processed foods. We also need to focus on improving sleep and reducing stress. There are medications that we use in pediatric endocrinology, adult endocrinology, OBGYNs, and in primary care to treat this condition. Some of these medications can be metformin or birth control pills, hormonal contraceptives, or anti-androgen medications to help with the testosterone or hair growth, and acne treatments, and the GLP-1 medications in select patients. We often talk about mental health support as well because this is critically important. We talk about dermatological support because skin and hair symptoms can significantly affect quality of life. And honestly, treatment should never be purely cosmetic. We're trying to improve long term metabolic health, hormonal balance, cardiovascular risk, emotional well being, and overall quality of life. Now, as a pediatric endocrinologist, I often talk to parents, and I want to talk to parents about what you should watch out for. Because parents often ask me, when should I worry? Things that deserve evaluation include persistent irregular periods more than 2 years after menarche. So, after a child has started having their period, if the periods are irregular after 2 years, parents should pay attention. Or if the child has severe acne or excess facial or body hair, if they have rapid weight gain, thinning hair in the scalp, or darkening around the neck or underarms, that is a reason that parents should pay attention. If there is a strong family history of diabetes or PMOS or significant insulin resistance, parents should pay attention. But importantly, families should avoid panic. This diagnosis can feel overwhelming initially, but with proper care, many patients do extremely well. Now, let's talk about a few questions. Why was PCOS renamed PMOS? Because experts felt the old terminology did not accurately reflect the endocrine and metabolic nature of the disease. Another question that I get often is, does everyone with PMOS have ovarian cysts? And the answer is no. Many patients never actually had ovarian cysts. The next question I get sometimes is this just a cosmetic rebrand? And no, the goal is improved medical accuracy and a broader understanding of the disease. Really important to understand that symptoms can often begin during adolescence, so teenagers can develop PMOS. And again, PMOS does not naturally mean infertility because many women conceive naturally or with some treatment support. And like I said, thin women can absolutely have PMOS. Now, another question I get is, why does insulin resistance matter? Why do we care so much about insulin resistance? Because this drives many hormonal abnormalities and long term health risks. The biggest misconception about PCOS was that it was only a reproductive disorder, but we know that it's actually a complex endocrine metabolic condition affecting the entire body. The biggest takeaway from today's episode is this condition was never simply about ovarian cysts. And the shift from PCOS to PMOS reflects a broader understanding of what patients have actually been experiencing for decades, which is endocrine, metabolic, inflammatory, reproductive, and emotional, as well as systemic symptoms. And hopefully, more accurate terminology will lead to earlier diagnosis, better education, reduced stigma, and more comprehensive care. Thank you so much for joining today on the EndoKids podcast. If you found this episode helpful, please share it, subscribe, and leave a review. And as always, If you have any questions about PMOS or PCOS and would like to have your child evaluated, please contact us at www.endokidsconcierge or look at our website for more information. Thank you again for listening and thank you for your time.
Thank you so much for joining us on the Endo Kids podcast. We hope you're leaving with a little more knowledge and a lot more confidence. If you have questions, stories, or topics you'd love us to cover, please send them our way. We love hearing from you. And don't forget to check out our website, www.endokidsconcierge.com, for free resources, guides, and more ways to connect. You're not alone on this journey. We're here to support you and your family every step of the way. If you enjoyed this episode, don't forget to subscribe to our podcast so you never miss an update.